webinar of the International Cardiooncology Society. My name is Steve Caselli. I'm the Executive Director, and we're glad to host you today for our first Journal Club of the year. I want to say a word of thanks to our sponsors, AstraZeneca, BeiGene, Bristol Myers Squibb Pfizer Alliance, Eli Lilly, and Sumitomo Pharma. And it's a pleasure today to welcome Dr. Justin Song, who is currently an internal medicine chief resident at UCLA here in the United States. And he'll be joined in the discussion by his mentor, Dr. Saad Mahmood, who is Assistant Director of Cardiooncology at St. Francis Heart in Long Island, New York. So, Justin, thank you for your presentation today. We look forward to hearing.
Thank you so much for the warm introduction. Good morning, everyone. Today, I'd like to talk in our journal club for ICOS about a paper, Cardiooncology Rehabilitation for Cancer Survivors with High Cardiovascular Risk, which was a randomized clinical trial published in 2023 with first author, Dr. Viamonte and her group. With me is my mentor, Dr. Mahmood, and I'll go ahead and get started with the discussion or with the presentation of the case of the journal paper, and then we will move into a discussion afterwards. So cardiovascular disease is the top cause of morbidity and mortality in our patient population of cancer survivors, both from traditional risk factors as well as from cancer-directed therapies. And so looking at effective strategies to improve the fitness and control risk factors in cancer survivors is really important. ICOS and AHA have put out guidelines recommending cardiac rehab in the cancer survivor population. And a recent review in JACC Cardiooncology highlighted some risk factors as well as some barriers to obtaining cardiac rehab, but also the importance of evaluating a multimodality approach to cardiac rehab. So in a few papers so far have come out demonstrating that exercise-based cardiac rehab enhances cardiorespiratory fitness and survival, both in non-cancer patients where supervised exercise cardiac rehab has improved fitness and blood pressure, and then there have been a number of trials also showing that cardiac rehab that's exercise-based has also improved morbidity and mortality for cancer survivors. The research gap right now is that there hasn't been a rigorous evaluation of multimodal rehabilitation in cancer survivors. So in addition to exercise-based cardiac rehab, also implementing nutritional support, psychological support, education about risk factors for healthy lifestyle management. And this hasn't been really studied in cancer survivors, especially cancer survivors at high cardiovascular disease risk, which we'll kind of talk about the inclusion factors for that population in a bit. And so the core trial design discussed in this paper asks the question, does a structured and supervised cardio-oncology rehab program improve cardiorespiratory fitness compared with a more community-based exercise intervention? So this was a randomized controlled trial and single-blinded, taking place in 2021 to 2022. So all cancer survivors over the age of 18 who had curative treatment completed 2 months before inclusion and high cardiovascular risk, which was defined as one of two modalities, either via their cancer-directed therapies, such as anthracyclines, or traditional risk and comorbidities from cardiovascular disease, such as history of coronary artery disease. Patients that were excluded had previously participated in cardiac rehab, had active cancer, or contraindications to exercise. And notably, upon reviewing the protocol paper that the author group had published in the International Journal of Cardiology, the contraindications to exercise were more of a cardiac variety, such as active decompensated heart failure or unstable angina. And notably, they didn't mention excluding other like cancer risk factors such as bone metastases. And then in terms of history of coronary artery disease, this wasn't further established in their protocol paper instead of in terms of like specific diagnoses. The core trial design focused on an intervention called CBCR, which is the Cardiooncology Rehabilitation Program, which notably is 2 exercise sessions per week at the hospital's cardiac rehab unit, which involved around 10 minutes of warm-up, 30 to 40 minutes of aerobic exercise, and then 10 to 20 minutes of strength training. This was also supervised by a physiatrist or a PM&R doctor, as well as and led by a physiotherapist. This is contrasted with the usual care, which is community-based exercise training, which is purely supervised by a physiotherapist, but had the same intensity prescription as the CBCR group. Notably, the CBCR group also had individualized nutrition plan for all patients, as well as psychological sessions and monthly health education sessions on risk factor control, whereas in the exercise training group, all of the nutritional and psychosocial support was provided PRN as determined by an attending physician who would then refer patients specifically who they felt needed these specific supports. The primary outcome that was looked at was cardiorespiratory fitness measured by changes in peak oxygen consumption, the VO2 peak. Secondary outcomes that they looked at include physical function as measured by hand grip strength, sit-to-stand tests, as well as risk factor control and anthropomorphic metrics such as BMI, as well as lipid panel, inflammatory markers, and blood pressure. Other outcomes included daily physical activity records, quality of life, anxiety, depression, health literacy, and then also adherence and safety, both adherence to the exercise session attendance percentages as well as later on to the other sessions as well. And the scales that were used for some of these other metrics are mentioned here. The statistical analysis, both between group were compared as well as within group was compared by the authors. And overall, so 116 patients were assessed for eligibility, and then a number were excluded, and resulting in 80 randomized. So 440 were allocated each group, and a few were lost to follow-up. So in total, it was 38 and 37 respectively in each group. Here are some baseline characteristics of participants in their table 1. So demographics were collected as well as cardiovascular risk factors, and an extensive cancer oncologic history and treatments, as well as other cardiac treatments, medications, and diagnoses were also collected here. So the overall results, looking at the primary outcome of peak VO2 improvements, the intervention group, the cardiooncology-based rehab group, had a mean increase in VO2 of 2.1 compared to exercise therapy group, which was 0.8 in their scale of milliliters per minute, and the between group difference was 1.3, which was significant. And over here is a slice of one of their figures demonstrating the significant changes over this 8-week intervention. And exercise test duration was also evaluated based on part of the primary outcome, and the CBCR group had an increase of around 105 seconds lasting on the treadmill test, whereas the CBET group had an increase of 47 at the end of the 8 weeks. So the between group difference here was also significant. Secondary outcomes, including physical function, were also evaluated. The physical strength, hand grip improvement didn't really have any significant differences between groups, but the sit-to-stand test demonstrated an advantage to the intervention group. In terms of cardiovascular risk factors, there was a pretty significant drop in the systolics for the intervention group of minus 12.3 millimeters of mercury, and the community-based exercise group dropped by around 2. And we kind of see the drops in the systolic and diastolic blood pressures in baseline compared to 8 weeks, and seems like there was definitely a step down for the CBCR group and not too much of a change in the community-based exercise therapy group. Moving on to body composition, this intervention group actually had significant reductions in weight, BMI, fat mass, and waist to hip circumference, which were all significantly different compared to the CBET group. And here, the mean BMI is shown here from baseline to 8 weeks in the CBCR group in the bar chart. In terms of physical activity, the intervention group actually had a greatly increased amount of meds per minute per week, and this is kind of keeping in mind that the exercise intensity that was prescribed in the intervention over the 8 weeks was the same or similar amounts prescribed by the physiatrist team. And cholesterol levels are kind of shown here in differences, and all had improved significantly in the intervention group here on the chart over here. And then finally, in terms of the serum studies, the IL-6 and CRP were also evaluated. There weren't any between group differences in either marker, and either group showed any changes in the circulating levels. It's interesting that these serum markers were collected and maybe points to the fact that this database may be used for further exploratory analyses in the future, given the amount of extensive data they had collected. In terms of quality of life and health literacy, the quality of life improvements on their scale, which is a survey, had improved significantly in this intervention group and didn't have too much of a difference in the community-based group. Similarly, health literacy on their scale had increased a difference in the CBCR group at the end of the 8 weeks compared to the community-based exercise therapy group. Finally, the community-based intervention group had an exercise session attendance rate of around 68% compared to 90% in the intervention group, the cardiooncology rehab group. And strikingly, the unexplained absence from exercise session was 0.8% in the intervention group and 14.2% in the community-based comparison group. And as previously discussed, everyone in the cardiooncology rehab group had access to lifestyle education sessions, which were attended 100% by the patient population, as well as the psychological management sessions, which were also required and attended by all of the patients in the intervention group. In contrast, in the community-based exercise therapy group, only around a third had attended the nutritional follow-up, which was a referral determined by the attending physicians. Only around a third had been referred to by the a physician overseeing the community-based exercise therapy, and only around 65% had been referred by had deemed to be eligible to be referred by the attending physician for psychological support. Another notable finding was that there were 0 serious adverse events in either the intervention or the community-based exercise therapy group, and this is always kind of a constant concern in the background, especially in patients who might be a little bit more frail at the end of their cancer therapy or might have things such as bone metastases, but it's very important to kind of show this safety data as well. In terms of the unexplained absences, a few of the reasons for missed exercise sessions are down here below, including medical appointments or illnesses, but it was a pretty striking difference in the unexplained absences in the intervention group and the community-based exercise therapy group. Using that data, adjusted for exercise adherence, interestingly, the peak VO2 between group difference, so between the intervention group and the community-based exercise therapy group, was no longer significant after adjusting for exercise adherence. And exercise duration and physical function in the sit-to-stand differences remain significant. And when adjusting for adherence, the changes in quality of life, anxiety scores, as well as health literacy were also consistent with the unadjusted results, so no difference there in adjusted outcome analysis. And the lipid profile changes differed a little bit after adjustment, but still continue to be significant as well. So in terms of key findings, this randomized controlled trial in 75 cancer survivors with high cardiovascular disease risk, this 8-week cardiooncology rehab framework was able to demonstrate clinically meaningful improvements in peak O2 consumption, as well as risk factor control. And the community-based exercise therapy was able to improve physical function as well in the intergroup comparisons, but there were no significant changes in body composition, lipid profile, blood pressure, physical activity, daily logs, as well as quality of life or health literacy. And so the hospital-based cardiooncology rehab program may have promoted greater adherence because of its structured setting and close monitoring. Some of the implications for the study include that the intervention might be able to really benefit high-risk cancer survivors who are exposed to cardiotoxic treatments or chest radiation, but they do need referrals, and it can be implemented. In this case, it was kind of implemented in the hospital's existing cardiac rehab unit. So this demonstrates the scalability of this intervention, where you'll have existing physiatry groups and equipment and resources for patients who are cardio-oncology patients to be able to access and participate in this intervention. And so, because exercise is currently important and well-established as supportive care for improvement in cardiorespiratory fitness, it was important in this case to consider a multimodal lifestyle modification. So in this case, the psychological support, and nutritional support, in addition to the exercise therapy, was able to have sustained and significant outcomes in multiple factors of quality of life, risk factor modification, health literacy. And prior recent reviews have really highlighted the need for more randomized controlled trials that are kind of focused on these cardiac rehab-based interventions. And so there are improvements in peak VO2 and muscle strength that are linked to better prognosis. And so physical fitness being associated with reduced treatment toxicity, cardiovascular disease burden, and cardiovascular mortality, as well as in other exploratory analyses where cardiorespiratory fitness after cardiac rehab was associated with lower mortality risk as well. And some key mechanisms behind some of the positive outcomes that the authors found in the study could include the clinical environment and structured setting when they were able to utilize the hospital-based cardiac rehab, as well as the support of psychological support and nutritional support, and kind of coming together as a multidisciplinary ability to both address the cardiorespiratory fitness outcome of patients as well as the other outcomes that were important for their overall chronic management and prevention of cardiovascular disease. So overall, the behavioral intervention and support may have led to increased health literacy, as well as the knowledge and tools for the patients to be able to manage their health after the cancer treatment. And this is kind of reflected in increased daily physical activity levels in the cardiooncology-based cardiac rehab group compared to the community-based exercise therapy group, despite them both having similar exercise prescription intensity levels. In terms of extending cardiac rehab to cancer survivors, the trial was able to demonstrate the scalability of the cardiac rehab unit and how they were able to apply this. And a lot of hospitals will similarly have cardiac rehab or acute rehab kind of facilities available to them where a physiatry team is available. And so this is definitely able to be scaled. I think the one important aspect as well is the multidisciplinary support that the patients received in this case. And so having access to nutrition support, mental health support, as well as lifestyle education management was really important and key for some of the other secondary outcomes that the patients had improvements in. One drawback or one limitation currently is sort of the lack of insurance coverage for cardiac rehab in cancer survivors with high cardiac risk. And hopefully this study and similar studies can kind of demonstrate to insurers and the overall cardio-oncology community how important cardiac rehab can be for both prevention and functional improvements in cancer survivors. And then other core components. So the core components here was exercise program, but also health education, dietary modifications, and psychological counseling. Limitations in this case were that it was a single-site study, as well as a limited diversity in cancer type representation, where most of the participants either had breast cancer or lymphoma. There was a smaller sample size, although the study was powered to detect changes in cardiorespiratory fitness. It wasn't powered to assess any differences in subgroups, for example, men versus women. Overall, the core trial really shows the importance of having this multimodal intervention for cancer survivors who are at high cardiovascular risk. Not only was the exercise component important, but also the nutritional and psychological support. And this overall intervention was really important and effective, and so should be considered for incorporation in standard of care for any cancer survivors with high cardiovascular disease risk. In the future, scaling this intervention to a variety of different practices, university, community hospitals with cardiac rehab units will be important, and kind of integrating it in long-term plans and guidelines as well would also be a great future direction for this intervention. And in summary, so the intervention compared with community-based exercise therapy demonstrated improvements in PPO2, risk factor control, exercise adherence, quality of life, and health literacy. So a comprehensive care model delivered by a multidisciplinary team would really be able to maximize exercise benefits as well as overall lifestyle modifications and risk factor control in this population of cancer survivors at high cardiovascular disease risk. And it should be considered for incorporation into standard of care in this patient population. And at this time, I'd like to invite the panel to discuss the paper and then presentation.
That was a great summary. Thank you so much. Before we kind of get into the larger questions or comments that may come from it, if we just look at the study, how do you think it was designed? Do you think that it was designed in an appropriate manner?
Yeah, so I was taking a look at the their protocol paper in the International Journal of Cardiology, and Dr. Mahmoud, feel free to chime in here. I think in terms of the statistical design, they had definitely calculated the appropriate patient number and sample size in order to adequately power their evaluation of the primary outcome. I think that the outcome being the intervention being 0 to 8 weeks was a little bit shorter compared to the other studies, such as one of the trials called the Brexit trial, looking at breast cancer survivors and how exercise-based cardiac rehab improved their outcomes. Kind of featured around like 24 weeks of an intervention or so. But in this case, the 8-week intervention demonstrated significant changes in the cardiorespiratory fitness. I think it was definitely key for them to look at exercise adherence. And I think that not only is that kind of like was that a primary component of one of the drivers for the change in cardiorespiratory fitness, but also demonstrates that one plus side of this kind of hospital-based cardiac rehab that was cardio-oncology-based in the intervention demonstrated increased adherence, and that might be one of the strengths of the intervention actually in terms instead of kind of something that limits some of their findings of their primary outcomes. And I think in terms of being more of a novel study, adding this to the psychological and nutritional support components was really key to kind of show these changes in secondary outcomes, which are also really important for overall risk factor control and long-term prognosis for the cancer survivor patients, where we know that cardiovascular disease is one of the top causes of morbidity and mortality.
So they randomized patients apparently, but the difference in compliance, by their various measures was strikingly different. Obviously,
exactly.
As you found that they 100% of the exercise or cardiac rehab group, did the nutritional and psychological support. 100% of them did it, and then there was a big drop off in the other group. So,
just wanted to clarify the point. So, the psychological and nutritional support and education was kind of prescribed by the attending in charge of the community-based exercise therapy. So, they were only referred to the nutritionist, for example, if that attending physician specifically requested a referral for them. So, they weren't necessarily all offered nutritional consult.
No, I understand. It's when you have a program and you say these are the components of the program, and then you gotta adhere to all of these things, and the patients agree to that. It's really amazing that they had 100% participation.
Exactly.
And then on the other part, it's it might have been suggested or recommended, but most of the time that people they may or may not follow through on those things. Especially if they have a busy day or something. So anyway, I think it was a very well done study and randomized, but it also tells you that a system like they have at the place where they're doing that cardiac rehab, they have a system and all the parts are present. And that really made a huge difference, I'm sure. And so, Dr. Mahmoud, what would you say?
I agree with you. I mean, I think the punchline of the study, which wasn't in the abstract, is that the peak VO2 difference disappeared if you account for adherence. And it appears to be that this was a study of real world versus an organized program. And certainly we see these patients all the time when we're getting their cancer therapy, and they'll complain that I'm just so fatigued. And it's and obviously the flexibility, say, well, while arranged for them to have home physical therapy, etc. But getting the patient to sort of commit to spending a lot of time in the activity as well as thinking more about it, etc. Apparently that makes the greatest amount of difference. And how we implement this across this so-called core cardio-oncology rehab at various sites. It's very clear it's not simply writing a prescription for home physical therapy, because often that level of activity dissipates once that prescription is done and insurance starts paying for it. But it's very difficult to have, and it requires a lot of work from our part to actually build this sort of infrastructure that this group in Portugal has in terms of the nutritional aspect, psychological aspect, and this group community type sections, which sort of I think probably elevates the patient's ability to participate in this sort of exercise. So it's not. I don't know how much of this is simply having a physiatrist and a physical therapist, which was the center-based arm versus the community-based arm was just a physical therapist. I think it's more actually the environment that one creates in terms of enhancing adherence for these patients.
Yeah, I completely agree with that. Jose, what would you say about the concept that, so they did this trial and they showed an improvement in peak VO2 that was significant, although it was relatively small, but still I think those things are hard to demonstrate. And then many other parameters, how far they walked and, various and sundry other things all pointed in the same direction. So do you believe that they actually improved the peak VO2 and all the related parameters by this program?
So yes, I think they did a good job. However, I do have a lot of questions about this study, right? So if we break down the study with the title, it's saying that it's a high cardiovascular risk population, right? But it seems like they're defining that based on the treatment and not necessarily by the patient's intrinsic risk factors. Because in the study, barely any of them had ischemic heart disease or heart failure at baseline or valvular disease, which is one of the criteria. So they're basically saying that they're high risk predominantly because of the type of therapy that they receive. However, the time that elapsed between the diagnosis to the enrollment was barely 2 years. And, it's not necessarily frequent that we see anthracycline-induced toxicity so quickly after finishing, within the first 2 years. Sometimes we see it a little later. So that's one, are we talking about high risk cardiovascular risk because of treatment or because the patient, in addition to treatment, has their own, cardiovascular risk factors or comorbidities? And then the second point as to whether or not, the peak VO2 improved, et cetera, the majority of the patient, the mean age was only 53 years, and the standard deviation was only 12. So at least in my clinic, and I guess it depends on where you are in the world, I tend to see, yes, young patients, but I also see a lot of older patients. The other comment is that the majority of the patients had breast cancer, and they were early stage breast cancer. So from when I see a patient in clinic and in my mind, and I'm talking about rehabilitation, I also ask them questions, particularly for the breast cancer patients. One of the most common complaints is neuropathy from taxing neuropathy. So here, we don't document how many patients had neuropathy at baseline and how that could influence their ability to rehab. And the majority of the patients were also very early stage breast cancer. So should the study be for any cancer survivor, or should it be for breast cancer survival, since more than 70% of patients were early stage breast cancer? So a younger patient population, early stage cancer, probably, not, just like the standard of care cancer treatment. It's not like years of chemotherapy or the metastatic breast cancer patient who remains on treatment, beyond a year. And also to Justin's point, are we really saying that 2 sessions per week, for 8 weeks of 16 sessions, is enough, for these patients? I know there was a difference, but what happens after those 8 weeks? How do you sustain that potential improvement?
Yeah, these are all really good points. There was one question in the chat, Justin, that you probably could answer very easily. It says, what is the CBET group?
The community-based exercise therapy group that the overall intervention, which was the more cardio-oncology, which was hospital-based physical therapy group, was compared against. We previously had discussed a study here in cardiooncology, and one of the questions that I have for the panel is basically, based on prior data and this data, would you recommend rehabilitation during, or would you wait after they're finished treatment? Because in the study, they waited until treatment was completed to start rehabilitation. Or should the message be, should we start during?
Yeah, well, I was just getting to that, Jose, so you beat me to it. But I think there's the breast cancer population, and you already mentioned that, which, that's the majority of the patients in this study. But, if you see many other patients, many other types of cancer, and, older and have a higher rate of cardiovascular events, et cetera, such as lung cancer or multiple myeloma or, even GI malignancies, to what degree does this, this information apply to that population? And that's clearly the population that would benefit from an organized exercise program. And I think that the reason that you saw it, or, my estimation, the reason why you saw the difference between the groups is because the group that was in the intervention arm did everything. They went to all the nutrition and psychological stuff. And, when I'm seeing a patient with heart failure and, I'm trying to convince them to do cardiac rehab, which is a struggle anyway, the biggest part of cardiac rehab, I think that makes the biggest benefit is their frequent contact with nursing personnel. And they, reiterate the medicine compliance and, they check their vital signs and, talk about sodium restriction, and maybe they talk a little bit about diet while they're doing the exercise. And I mean, there's all these touches where the patient gets important feedback or encouragement. And I think that whole picture is what makes the difference in my book. But Dr. Carver, what would you say?
Yeah, so we don't plan it that well, but last week we had a whole discussion about cardiac rehab. So this is a nice segue to today, and sort of completes the picture to some extent. I think if you look at the VO2 at the start, it was really not that depressed, and I think that this was a population of people that were already in fairly decent shape to begin with. So it does temper some of the findings. I think the major benefit is that they've shown that this is safe. There were no adverse events in either group, so this is safe no matter how you do it. And the takeaway is that any exercise, even if you don't complete the program or you're absent, is better than nothing. It's interesting, group pressure and group
prolonging make a big difference in people continuing the program. And that may be one of the things to take away, even in community-based programs, is somehow bringing people together at the start and maybe in the middle to create a community and some peer pressure.
Yeah, that's actually a really good point. And, I suppose that's kind of what I'm talking about when I, try to convince the patient just to do cardiac rehab from a traditional cardiac point of view, the post-MI or post-PCI or, heart failure with reduced EF, it's still a challenge to convince them to do it, especially to come to a hospital and do it 3 times a week, which is what we usually do in the U.S. anyway. But so I think that creating that community and peer expectation is a really key piece. Dr. Mahmood
can I add something that just because of what you said about convincing people? The other great value of this, forget any of the limitations, is that you can show patients data that it's safe, that there's a benefit, and that may help in the discussion to get them to be more compliant. So it's a great value of the paper just for that.
No, Joe, I agree with that. The way I sell cardiac rehab, and I struggle with what the same thing that Dan is struggling with, which is adherence. And our cardiology patients have a greater burden on them than our heart failure patients. Our heart failure patients aren't coming in for weekly chemo or having innumerable CT scans or PET scans. So for cardiac rehab, I point out the mortality benefit and keep it simple that there's great observational data. Now that 80,000, 90,000 people studies that show that for cardiac rehab, there's survival benefits. We haven't quite gotten to that point with core cardiooncology rehab because it's not as well adapted. And the sample sizes will be very difficult to achieve for hard endpoints such as does it lead to improved overall survival, which is something oncologists often ask us, or does it even lead to fewer heart failure admissions or fewer, there's some limited data from this field showing that those more active cancer patients have fewer hospitalizations. And so I suspect that as the number of patients who've undergone core cardiooncology rehab, with everything else goes up, we'll be able to show that actually there's hard endpoint benefits, either whether through cardiovascular events or maybe even overall survival. I say overall survival because, oncologists use ECOG and other scores to decide who to give cancer therapy to. So if you're more active in cancer therapy, it's possible that patients who are needing second, third line agents will be able to be candidates for these agents. I think there's more work to be done in this field. It'd be hard for me to tell a patient your PPO2 is going to go up and convince them to go to core cardiology rehab, but I say that there's some data to show that it improves hospitalizations. To answer Jose's question that came up, you were talking about what's the optimal timing for doing cardiology rehab. There's a really nice paper by Vandershoot and colleagues that was published in JACC Cardiology in 2022 that showed that those patients who do chemotherapy, cardiology rehab, or exercise during cancer therapy generally have improved functional capabilities. But among those who are unable to do it during cancer therapy, if you put them into an exercise program after cancer therapy, they're able to achieve similarly improved functional ability. So the answer that we're all saying is that now is the time. The present is always a good time, but even if the patient is not ready and wants to do it later, there's still some clear benefits from that. The third point I guess I could make is that the reason this is a distinct study than previous ones like Brexit is that they try to identify a so-called high-risk population. Sort of like the SUCOR study versus SUCOR MRI study, with the latter being focused on so-called high-risk patients. And I think there's definitely value to that effort to see that, for instance, the previous studies like Brexit trial, they excluded anybody with any valvulopathy. Right, whereas the moderate valvulopathy is an inclusion criteria, albeit very few patients were actually enrolled with the valvulopathy here, and that this is relatively healthy population. I can't speak for the authors, but I wonder if they chose a healthy population with curative chemotherapy, because then you can have a small sample size. Otherwise, you need to account for mortality in your sample size calculation. You probably need much larger studies in more advanced malignancies where other things are competing as well.
Yeah, I think that the question of, could you have changed the population to, give you a bigger question, bigger answer, that's always a debate. It doesn't matter whether you talk about cardiac rehab or you talk about preventive therapy or early diagnostic therapy. The population that you're studying matters greatly in terms of whether you're going to find an outcome. So, I think it's a, potential criticism of this particular study. I wouldn't focus so much on the limitations, but rather the positive effects of the study, which show a significant exercise improvement by multiple parameters, the PPO2 and the walking distance and strength and other measures of functional status that's STEAM improved. So I think that's good. It's impressive in that way. But how do we apply that to everybody or can you apply it to everybody is really the essence of the question. And then the other part is, how do you deliver that expertise or that program into multiple places? I mean, obviously this location, they have their cardiac rehab program down. They got a system and it's working, highly efficient, and there you go. But can you duplicate that at community hospitals or somewhere else? That's the real question. And then before we got on side, the same or similar authors had published a paper just like yesterday or whatever in JACC Heart Failure about a home-based rehab program and that it was not inferior in heart failure. What do you think about that as a way of extending this type of thing to a home-based system?
Right. It seems like, so if obviously, I use home-based exercise program all the time. I prescribe it all the time for our oncology patients. And to the point that we actually found a company that for our Medicare patients will see them and bill Medicare here in New York. And when you do home-based care, you in theory have a captive audience. The patient, they're coming to you and you're going to have them do the exercise. But it seems like in this study, and Justin correct me, but it seems like there was pretty comparative, reasonable adherence to exercise in both arms, and there's something about the nutritional aspect, the psychosocial aspect of the community, etc. So I always start with home-based for these patients because it's sort of, like I said, as I was saying, these patients are often coming in for chemotherapy or PET scans or CTs or oncology visits, and now they're seeing a cardiologist, which itself is an extra visit. So to add on further visits to the hospital, it becomes a full-time job for them. So I think a home-based approach is a great idea. And with that, I've based on the study been working with our oncology rehab people to say, well, how do we integrate a nutritional session as well as sort of a group experience for these patients, which I think really motivate them for long-term benefits from exercise.
Yeah, I think that's true. If as Joe suggested, if we can make it, they're a team against the world sort of approach. They identify themselves as a group that is going to get better, and then they can motivate themselves with your encouragement, and then meet halfway through or something, meet again, and sort of trade notes, et cetera, to understand how things are going. Then a home-based program could be a community, at least by extension, with some sort of adaptation like that. Justin, there was a comment in the chat. It says, "I wonder if you could tailor the cardiac rehab based on the patient's restrictions and risks." From this study, can you make any comment about that?
I think it was probably a lot easier in the case of the comprehensive cardiooncology rehab intervention in order to tailor because they had an active physiatrist supervising all of the exercise sessions in addition to physiotherapists. So the PM&R doctor would be able to kind of change around the exercise prescription based on based on the individualized assessment of the patient. Whereas kind of in the community-based exercise therapy, there's only one PT, and they were kind of in charge of running the overall sessions. And so I think having both the physiatrist and the PT at the hospital-based intervention program could have allowed for increased individualization, and maybe that kind of powers a little bit of the adherence as well, where the patients feel like they have more individual attention. And for example, if the physiatrist is making changes to the exercise prescription or intensity, which they didn't really touch on in the paper, if there were any changes made, but if they were able to do that, it could make the patient feel more motivated to come to sessions where they kind of feel like they're getting more of a personalized experience, as opposed to more of the standard community-based, where everyone's just following the exact same exercise intensity prescription. And to the other panelists' points previously, this is more of like a healthy population, early stage breast cancer predominant, and it would be very interesting to see future directions of where we can kind of more measure the impact of a physiatrist or a PM&R physician if we have more of a sicker population or more of a population that has a tendency to bone metastases or more of an increased stage of cancer, and see if the physiatrist supervising the therapy would be able to make an even greater impact in terms of individualized exercise prescriptions throughout the course of an 8-week or 12-week or 24-week program, and being able to kind of change course there might lead to even greater significant differences in groups compared to the community-based exercise therapy. And then in terms of the prior discussion, I would also think it's interesting as a future direction to kind of study. In this case, we saw that exercise session adherence was really important and kind of powered a lot of the differences in the cardiorespiratory fitness. And I was wondering if maybe this kind of home-based PT, especially now with greater internet communication infrastructure, would be able to kind of help with the adherence gap. Maybe patients who were unable to attend an exercise therapy for whatever reason could kind of at least have a substitute home-based PT, like kind of PRN basis, and that might be able to kind of be a band-aid to stopgap that kind of adherence gap in some programs as well.
Super.
Cool. Give me an example.
Go ahead. Well, I was just going to, Jose, there's a question in there about specific cytokines or some myokines. I don't know exactly what those are. Maybe more sensitive in estimating a change than any kind of positive change in cardiac risk factors. Do you think there's any promising cytokines that would have been better in terms of showing a benefit? I think you're muted, Jose.
I'm just saying that I'm not sure I'm able to comment on that, just because I don't know about these chemokines or myokines. So I would defer to others if they know, if they have an opinion about it.
Yeah, I mean, I assume if you're talking about like, troponin or NT-proBNP or something like that, maybe those aren't exactly cytokines, but if that's what you're talking about, then, I don't know how they would have been any more sensitive than a control of blood pressure or other factors that they looked at.
IL-6
what were you going to say? Yeah, sorry.
IL-6 is not a routine lab, even for our CAR T patients. It's not routinely checked. So it's possible they have a biobank. I can't speak for them, and that may be useful in the future if we find more biomarkers. To your question to Justin, and just to echo what Justin was saying, I can think of patients with bone mets who, how would they be candidates for this sort of an intervention as a study in terms of twice-a-week sessions. And I continue to be amazed by our physical medicine and rehab colleagues, because they have an expert consensus statement just on rehab for oncology patients with bone mets. And I think this is really an opportunity for us to engage more with our physical medicine rehab colleagues, where they can really work with our physical therapy colleagues to tailor exercise for these patients who may have limitations in terms of what they can do. In this study, they're doing resistance training, they're doing cardio, and that can be a lot for certain patients.
Yeah, that's a really good point. All right, Joe, you want to summarize what's happened today?
Yeah, so interesting. I was thinking they're going to bring everybody back in a year and see if there are any differences between the two groups. Get them to run and see what the VO2s are. So as you guys know, there's an American football game on Sunday. So with deference to Charlie Porter, we will be happy at Penn to offer rehabilitation to any of the Kansas City Chiefs who survive the Super Bowl. Fly, Eagles, fly. See you guys next week.
All right, thank you so much.
Bye. Thank you so much. Thank you.
See ya.
Thanks, everyone.